Assalamu alaikum. Hafiz, are we set? Hello.
Ewe, meeting ebido gwakwa mana adịka ekwugbo afọ break emeka rinsi to the host.
morning. We are welcome to this week workshop, which is going to be on balance treatment or rehabilitation. This one workshop in managing stroke and Parkinson's disease. Our facilitator is ready, set. So without wasting much time, we join him for us to start. Thank you all and happy listening and reading. Over to you, sir.
Good morning, everyone. Thank you, Mr. Jibril. And thank you for having me here once again. I want to take opportunity to welcome the participants for this workshop, which is the third or fourth of among the series of this topic, balance. There were previous presentation or workshop on assessment. There was also practical demonstration on assessment. Some of the skills and some of the assessment method were demonstrated, which was around 2 weeks ago. So I think this is going to be the next aspect of the topic, that is to see how we can manage neurological conditions when there is impairment of balance. And this is what this presentation will be taking us through. So thank you once again. And so I think we can start now. Let me share the slide. So good morning once again. My name is Muhammad Ali Abba, a lecturer at the Department of Physiotherapy, and my area of specialization is neurological physiotherapy. Yes, we have, I've earlier mentioned, we had previous workshops on the assessment of balance. We also had practical workshop demonstration of balance also on neurological conditions. So today, the topic will extend to the management aspect of balance. And so we'll begin. Balance exercises, yes, they are activities designed to improve balance, as simple as that. Any activity that we get involved that will enhance balance or improve balance, these are balance exercises. They are activities carried out in various body positions to improve balance. This exercise can be carried out in sitting, in lying, in standing, in all the fundamental, including walking, in all the fundamental positions that we know, and also the derived positions that we are aware also. Then some activities will be incorporated, some instruments may be incorporated, some tools may be incorporated, or some movements may be incorporated into this position. Or it could just be to be able to hold that position for a certain period of time. These balance exercises, yes, they can be conducted at home by the patient and the patient relatives. They can be conducted at the clinics. They can be conducted at the exercise laboratory labs. That's what I mean by this is the gymnasium that we have in the clinics. I most times prefer to call them exercise therapy labs than gyms, because we do more than what is done in the gym. Because we have assessment, we have diagnosis that we make, we have review of patients that we do, and many other things. So that's why most time I prefer to call them exercise therapy laboratories. So this exercise can be performed individually. That's one-on-one program, or they can be conducted in groups. So most of the time in our gyms, we can conduct this in groups, or bedside when patient is on admission at the acute stage or the subacute stage, or in our cubicles, we can carry out the one-on-one exercise programs. These exercises are applicable to a variety of conditions, not just neurological patients. Orthopedic conditions also, or athletes also have part in this. They also enjoy this kind of exercises during rehabilitation. But we are focused on neurological conditions, especially stroke. So these exercises require a lot of supervision. So they have to be conducted by being supervised. I've mentioned at the first point there on this slide that they can be performed at home. Yes, they can perform at home, and that will be under supervision, maybe by the physiotherapist who pay the home visit treatment, or if this thing has been done by the physiotherapist at home or at the clinics, then they are able to see that this thing has been able to be performed to a satisfactory level, that they can do it at home without so much concern. Then they can do that. So balance exercises improve, these exercises improve balance by increasing strength, by increasing muscle endurance. So it means some of the exercises involved are those that improve strength, or in a way they are involving muscles, the muscle fibers that has to do with strength. Then they also improve balance by increasing muscle endurance, or they increase flexibility in muscles, so that exercises or activities, because that is our target, for patients to be able to carry out their activities without fall. Then also they will be able to do it with much ease when there is much flexibility, better flexibility in the muscles. Also, they increase the balance by also improving muscle coordination, and as well increasing or improving proprioceptive function. The benefit of balance exercises. Yes, the benefits of these exercises are to improve confidence. Just like what we discussed previously, that the aim of balance primarily is to prevent fall. So if a patient is able to develop good balance, then the confidence will be improved for mobility, moving from one place to the other, reduce the fear of fall. Maybe they feel they're at risk of fall because of the balance impairment, or they had previous history of fall. That means they won't be able to carry out their activities without fear. So when the balance has improved, there will be a lot better improvement in the fear. Then overall, the risk of fall, or the incidence, the occurrence will now reduce. Then there will be increased mobility. If there is less fear of fall, if there is If there is confidence, there is improved balance, then the patient will be able to move from one place to the other without much problem. Then this will increase activity because they can be able to carry out activities independently. And they will be able to, from activity, they will be able to go into community to conduct activities like we have mentioned in the assessment of balance, that without all these things, this could even impact negatively on the psychological status of the patient. Some may even have depression because they are going to be isolated when they cannot move around, when they cannot conduct activities by themselves, when they cannot go into the community to participate, to attend wedding, for example, in our country, in our environment, we know attending events are very, very important. Your siblings' events, your siblings' children, your close friends, and many other events that could be official or non-official, and many other activities. So if one is unable to do this, will impact negatively, not just physically, but also will impact also negatively on the psychological status, such as what I mentioned as depression, which could be a problem. So if the balance improves, all these things may not be of concern, and overall quality of life will improve. As we know, the domains of quality of life has to be physical, psychological, social, even sometimes financial, and many other things. So if you improve individual domains, it means the overall quality of life is going to improve, and they're going to do better in life. You see them smiling and not knowing absolutely the reason for that. So, but these exercises, when being carried out, are affected by several factors. This is just to mention a few. Age, yes. We know that with age, there are going to be changes in the musculoskeletal system, in the nervous system, in the many of the systems. And these systems help us maintain the balance and posture. Yes, we know that with advanced age, yes, of course, we know that there are attacks. A certain individual that could be the limit of what the patient can do. And with younger age, we expect that this is the level of this is the minimum in which a patient can do, and the patient can do much more than that. But these are not hard and fast rule, because there could be elderly that are very much active than the younger individuals. Depends on the premorbid condition. That's why I have this second. If the patient is an athlete, if the patient is very, very much active, and things might be easier for the patient, even though from the period of hospital stay to discharge to many things, there could be deconditioning of some of these systems. But even as at that, the premorbid condition also plays a significant role. So apart from that, the severity also overshadows all these things. Be it the age, the premorbid conditions, they are all excellent, but the severity of condition will not let the application of so many things. So it has to be at the level of the severity. In fact, there are some exercises that will not be done at a very high that are with very severe conditions. So then the cognitive function, because most of these things will require input from the patient. First of all, they have to understand, they have to follow instruction, they have to receive instruction, they have to follow it by planning, executing the task, and so on, until the planning, executing, maintaining the task, and also terminating the task. You ask them to stop this, they stop. You ask them to continue doing it, they continue on doing it. You ask them to do it again, they do it again. So with cognitive function impairment or cognitive impairment, this may also pose a lot of challenge. So that's why overall assessment is very key and is very important, not just of the balance but other systems of other function to find out other impairments, whether the management will come much later or it can be conducted together with other impairment of, let's say, motor and other sensory impairments, or this could be conducted just alone. So these are just to mention a few. There are many other ones, but these are some of the key factors that could affect the application. Then safety, yes. I've mentioned this during the presentation on assessment, that we don't want a situation where we are just trying to assess, then a patient falls. What we are trying to prevent is fall. Then from assessment, we now cause fall. Then this could be a problem. So the same thing with the management also. The same thing with the balance exercises, balance training, or balance rehabilitation. We want to ensure safety by preventing fall, by installing confidence on the patient. So we need to use all the necessary tools available for us to ensure safety. This one of these could be external support from the physiotherapist by being around and be ready to support the patient, guiding the patient through the movement or the activity that is supposed to do, and also anticipating fall where the fall is coming and staying where necessary. If there is need for more than one person, 2, 3, to be able to carry this out, this task, maybe including the patient relative, is still okay. Then we can conduct these things at parallel bar, yes, using harness, which I know is not very common here, but this could also be explored. Then the floor of the flow of the environment for carrying out this exercise is very important too. If it's a hard surface or it's a sort of carpet or other things, will also help in ensuring safety, and also staying close by to where the patient can easily reach out to hold, or staying around maybe close to a chair or close to the couch that the patient know he can easily sit down, sit back, and so on. This could also be gradual progression is also part of the safety. The patient should be graduated from recumbent position to upright, from lying down, lying down, or from sitting up to standing position, and also up to the level that the patient can walk, can get involved in locomotion, in movement, in mobility, yes. So also increase, which is also just like increasing the intensity or the progression, duration, also all those parameters gradually adding to the difficulty, to the duration, to the intensity, to the other things. This is supposed to be gradual, yes. So instead of just standing and the patient falls down, probably because of orthostatic hypotension, or it could be because of the lack of balance, or it's because this thing has not been graduated. Yes. And also explaining the procedure to the patient, what the patient is expected to do, for him to understand, for him or her to understand the activity clearly, by demonstration, by doing practice with the patient before the actual activities. And so this also helps. Then the system integrity is checking the various system, which I've mentioned already, like in the premorbid, some of the factors that will affect the participation or the execution of this task. We make sure that there is the joint integrity, the muscles, the bones, the nervous system, of course, that they are of some level of activity or integrity to carry out such task, because we know by certain muscle strengths, we know that this patient cannot stand. Then why standing the patient? Let's finish everything in a lying position. Let's finish everything in sitting position. Then before we go to all these things, there are many activities that can be done in lying and sitting without going to standing that will aid in preparation for standing and walking. So we don't have to do the exact activity. Yes, it's supposed to be transferable activity that is supposed to be standing or walking, but we start with the preparation for that person to be able to achieve that position before we can do that. Then trunk function is key. Trunk function is very key to balance exercises, balance training. We have seen how during the assessment of balance that we have demonstrated many instruments or skills that focus largely on trunk, or some that mixed other assessments of other body parts with that of trunk. And we have demonstrated, I think I was one that presented the aspect of trunk last time in the two presentations. And I've taken time to discuss the importance of trunk function. Has to do with movement, mobility, has to do with stability, of giving stability to other body parts, and also sensory, especially proprioception, given the body position response, the proprioceptive activities, and many other functions. So that is why improving trunk, that's why you see most time in neurological rehabilitation, if the trunk is weak, then a lot of other things would not be possible. Sitting, standing, walking. If you have them possible, they will not be done as efficient as possible, and they will not be as good as it is supposed to be. So trunk impairment, that's why I decided to bring this. Trunk function is very key. Yes. Balance exercises, like I said, yes, they are indicated for neurological condition, and one of the conditions is stroke. Yes, it's indicated for acute, subacute, and chronic stages of stroke. But for a severity of mild to moderate for the stroke, one-on-one balance training for acute stage stroke, like I mentioned at the beginning of the presentation, which can be conducted 2 to 3 times per week. Or yes, these exercises can be quantified by number of repetitions. Maybe it's just to hold a certain, or is to do an activity 2-3 times, or is to hold a certain position, like I've mentioned in the beginning, is to hold a position for a certain duration. For example, we have seen during the assessments of, let's say, functional in sitting test, also during the assessment of trunk impairment scale, we'll see that also in the back balance scale, we'll see that the task is to see how a patient could sit. For example, when we take sitting as one of the tasks, that a patient is able to sit for, let's say, 5 seconds, then has good balance, is able to stand for example, using the run back test, is able to stand for, let's say, 10 to 20 seconds. The patient has a good balance. So the same thing. This exercise can be quantified if it's a task that requires the duration, then this can be quantified based on that, and also number of sets. You have 5 seconds for repeated 5 times. Probably that's your set. That's your first set. Then you have another set which is the same, and so on. So it depends on the severity of the condition, and it depends on the function of the patient. So for one-on-one training, group activities can be conducted, and it can be conducted more than 3 times, up to 3 to 5 times. Yes. So it depends on the up to 40 to 60 minutes per day. So it depends on the level of impairment of the patient. Then we have exercise progression for this balance exercises. I've just started talking about it. You can quantify it based on repetition. Then you can decide to progress it, to increase it from 3 repetitions to 4 repetitions in a set. Or you can decide to increase the number of sets. You do 2 sets per day or 2 sets per session. Then you increase it to 3 sets per session. It depends on, or you increase the duration, 5 seconds to 10 seconds. It depends on how your patient is, what the patient is able to do. If he's able to hold for 5 seconds and rest, you can do that, and make it to, you can repeat it many more times. If he's able to hold it for a longer time, which is okay. If he's able to just do it in a short time, then you can increase the number of sets and so on. Then some exercises can be more challenging if they are carried out in a higher exercise platform. For example, when the exercises are conducted in a mat, they tend to be easier. Or when you take them to a couch, the patient might feel it's a higher position and is feeling unstable, and it will be difficult for that patient to carry it out as effectively. So it's becoming more difficult or it could be that the patient is just the exercise is a stepping exercise that we have shown, for example, in the previous presentation of step test. Maybe the exercise is to carry out steps. So by increasing the height of the step, that is another way by you are increasing or progressing the exercise. Or number of repetition, like I've mentioned, number of duration, number of sets. Or it is the weight that you want to increase. Because in some exercises, the patient will have to be, we'll talk about it in a bit, that sometimes you are going to be allowing the patient to carry out many tasks at a time. And some of the tasks the patient might be doing is to carry weight. And you can be increasing or gradually increasing the weight, which will be more tasking for the patient to be able to maintain that, to maintain balance with the increased weight. Or increasing complexity or difficulty, increasing the height of step, increasing the height of the exercise platform is also another way. Altering base of support is also another way of making it difficulty, making it more difficult. Combination of different balance exercises is also another way of making it difficult. Combining cognitive tasks, combining upper limb tasks, lower limb tasks, many activities combined with your target exercise will make the exercise more difficult. For example, the base of support, alternate base of support, it could be that you are on a carpeted floor, then you decide to go on a foam mattress, or you decide to go on a wobble board, and so on. So these are ways of altering the base of support. Then from, like I said earlier, you can progress from recumbent to upright position. That's from lying position, lying down to sitting, to standing, and to walking. Can also progress using that. So types of balance exercises that we are going to be discussing today will be majorly 5, even though there are other classifications embedded in some of these things. So I decided to collapse it here for ease of clarity and for ease of discussion. I don't want to place some other things as exercise, balance exercise on their own, because on their own they are not balance exercises. So the first one we'll be looking at is the conventional balance exercises. These are exercises that challenge the body's equilibrium. Of course, all exercises for balance challenge the equilibrium. Yes, involve static and dynamic exercises. They are what we know and what we used to do all the time to our patients, and they require little or no equipment, very cheap equipment, easy to perform. So they involve balance exercises, a lying position, in sitting position, kneeling position, standing, walking, and transfer, whichever way that we are going to do these exercises. So we have the dynamic stability, which focuses on maintaining balance while stationary. Person is in a stationary position and trying to maintain the balance, just like we have talked about standing, just like that of the run back test, just standing to maintain standing for 20 seconds, or to stand on one leg stands for, let's say, 15, 20 seconds. So that's static stability exercises. So it improves strength because mostly recruits the tonic muscles, the tonic fibers of the muscles. So example, I've just mentioned it, standing on one leg, or just standing on the 2 legs, and so on. So the dynamic stability exercises, maintaining stability while in motion. Somebody is moving and is trying to maintain stability. The stability is being distorted, and is trying to overcome that and maintain balance. So example, working on uneven surfaces, overcoming obstacles, placing obstacles along the way, and making it challenging for the patient. So that's some exercises for maintaining dynamic stability. But these exercises are not conducted in isolation, just on their own. That's why I said there are many other exercises that are incorporated, that are incorporated as, because on their own, even though there are some studies that were conducted to find out if these exercises I've highlighted here on their own can improve balance, and being compared with conventional or some other forms of balance exercises to see if they could do better than the ones that have already been validated or applicable. For example, cognitive training or cognitive activities, they are not merely developed for exercise, for balance exercise or balance training. They are merely to improve the cognitive domains, depends on which domain is targeted, be it memory or attention or concentration or language, or whichever one. So, but incorporating it into the balance exercises will help improve more. But standing just on its own as balance exercises, then, for example, functional training, many functional trainings, yes, they could be upper limb, lower limb. They could be targeted at the motor activities, not really the balance outcome, but in a way, they could also help in doing that, and so on. So we have the first one, which is the perturbation-based exercises. Then we have training on unstable surface. We have the weight shift training, and we have the visual deprivation training, and we have the cognitive training, and we have the functional training. So we'll just be looking at them one after the other in a bit. So when we talk about perturbation-based balance exercises, they are usually external forces, unexpected external forces, usually being applied on a patient that would cause loss of balance. So the patient has to quickly respond and adjust the position or posture in order not to fall. These forces will come. These external forces will come from the physiotherapist himself by pushing the patient or by pulling, or it could be internal perturbations when you ask one to move rapidly, or you ask to walk, for example, on a treadmill. He has to continuously maintain the balance. Most of these things are usually done under harness or in a safe environment. And like I said, safety is very, very important. While assessing, while giving balance exercises, we don't want to cause any more problem that the patient will be bedridden or don't want to go back to upright position. So yes, perturbation. Then we have the weight shift. Weight shift training are designed to improve proprioception. Yes, this, as simple as it is just to shift weight from one side of the body or one side of the limb if the patient is standing, or from one side of the body if the patient is sitting, to the other side of the body. We have discussed, or we have seen this during the in a sitting position. We have seen this during the assessment using the trunk impairment scale, and we asked, and patient were giving instruction such as to laterally flex the trunk, which will cause shortening of the side that is being flexed and will cause lengthening of the other side that is being of the opposite side. Then in a way, there's also shift in weight to the other side. And we have also seen where patients were asked to lift their buttocks or to shift weight while sitting. And that this could be also conducted while standing. We are going to demonstrate that by God's grace later. Then we have visual deprivation, because yes, a lot of patients, especially stroke patients, they depend largely on visual input to be able to move around. So when this is deprived, you see that they won't be able to hold those position, or they won't be able to hold it for a required period of time. So by depriving the visual input, is forcing the patient to facilitate the use of the proprioceptive and the vestibular senses, especially the proprioceptive. So in a way, it's also training the proprioception. Then we have the functional exercises. Yes, these exercises should be tailored towards making sure that what the patient is trying to achieve is what we are training the balance for. We shouldn't just train balance, but we make sure that what are those things that the patient wanted to do. The patient wanted to be climbing upstairs and come back. But our focus was, because we didn't ask the patient what are those things that he wanted to do. We're just beginning to train the patient on maybe a wobble board, which it will train balance, but we have not trained him on the staircase that he wants to to do. So at the end, whichever tasks, whichever activities that we are going to engage the patient, we'll make sure that we are including those functional activities that the patient wanted to perform as primary function. All patients are individualized based on training and many other things that we conduct in the clinic, because patient A can come, that's the only thing the patient wanted to do at most is just to go to toilet and come back. Somebody's another patient's objective will be that he wants to go back to work. Maybe the first patient is a retired civil servant already. The target is just to go to toilet and come back. That he or she doesn't want people accompanying him or her to the toilet to ease him or herself, or to take bath and many other things. This other person probably is still younger person, still wanted to go out, wanted to go to the community. So it means the balance has to be trained on functional, on different environments that may encounter while the patient is going out to the community to perform his or her own duties. So we have just talked about standing from a chair. Somebody could just be that just want to transfer, stand up from this chair to the bed, and stand up from the bed back to the chair. We have a lot of people like that you see the whole day what they do is just go in from the room and come out to the sitting room, go to the toilet and come back. That's only what they wanted to do. They don't need they don't want help. So someone to reach out to objects to be able to pick things and come back. Maybe he or she has a shop and wanted to make sure that the shop is ongoing, that activities of the shop he or she is able to do it by him or herself, to reach out and grab whatever products that people comes to buy and give it out and receive the money, count it and take it back. Probably those are those things that he or she only needs to be doing. So like I said, climbing stairs, sorry, this is a mistake, climbing stairs and stairs also. So escalators, which is only maybe big cities in Kano. I mean, sorry, not Kano, in the country you could see that, or some other big buildings. Then escalators, yes, they are not too common. Maybe in Abuja, Lagos, and Port Harcourt, and some other countries. I'm not sure. As other states, I'm not sure, but maybe for Kano, I don't know if we have this. Then travelators that you usually see on the airport, because they are highly unstable. You are just to stand and it will just be moving you from one place to the other faster. But they are also highly unstable. So when one is trained on such type of instrument, then be able to carry out such function. Then yes, cognitive balance exercises that I've mentioned. This will involve, first of all, this will involve that the patient will be carrying out the exercises, balance exercises, and will also be carrying out another exercise. First of all, it doesn't have to be a cognitive task. Just for the patient to be able to carry out two tasks at the same time is also involve cognition. That is dual task activities or training. Then it could also involve cognitive tasks or cognitive activities, just like we have seen in the modified time up and go, in which there is an inclusion or there is addition of cognition or cognitive task, in which patient will be asked to, while walking through the 3 meters and returning, the patient will be asked to count backward from 80 to 100 and so on. So you see that this kind of task is very challenging for stroke patients. And I've demonstrated, I think during the last presentation 2 weeks ago, that most times you have your patient in the clinic, and they'll just be passing by, for example, or they will be carrying out some activities, especially let's say mobility activities, that they are walking around doing some things, and you could just be greeting them and asking them about one or two things. If they have some impairment in these activities, you ask them that if they really have to respond to you, you see them that they have to stop. They have to stop from doing any other thing they are doing. They have to even halt the walking, then respond to you, and making sure they are done, then they continue moving, because they cannot be moving, or they cannot be moving and carrying out that task, or they cannot be moving and carrying that task and be talking at the same time, because for them it's very challenging because of a lot of stroke patients, about a significant percentage of them come with cognitive impairment. So this can also help in making the balance more challenging for them. But when it's improved, it's going to help in making sure that the balance is excellent for the patient. Yes. Then we have the next category. From the conventional exercises, we have the gym-based exercises. The gym-based exercises, yes, requires some instruments, which most of them are readily available. Not all, but some of them we hardly check into a gym of a physiotherapy clinic, and you hardly not see this some of at least significant number of these instruments. One of them is the gym ball, which is always vividly displayed in our clinic. Yes. Then the medicine ball, that's the heavy ball that we have in the clinic, that the patient usually carries around or to perform certain tasks. Then the Bosu ball. Also, we have the balance pad. Then the wobble board. I'm going to be taking this one after the other. I'm going to be discussing some of them. Wobble board. I just write this so that I will not forget, because when prescribing wobble board, there are a lot of things we need to consider, which I will discuss this. Then we have the rocker board, which is also used. We have the steps, or the staircase that we have in the gym. We have mats, we have tether bands, we have various weights, harness for safety, parallel bar also for safety, and many other things. Then we have hydrotherapy. Yes, this is not very common here in our environment because of some of the challenges we have with maintenance, with supply of water, with supply of electricity, and many other things. However, I'll still say a few things about hydrotherapy or hydrokinesotherapy. Yes, these are water-based exercises that we can do to improve balance. They could include upper limb exercises using the various hydrotherapy gadgets that we have for resistance, for flotation, and many also lower limb movement. We all know that the characteristics of water that we have in the hydrotherapy also aids in improving strength, improving coordination, and many other things. Then trunk control exercise too. And one of the method is Halliwick method. Yes, this Halliwick method is 10-point method or approach of hydrotherapy, and among those 10, one has to do with mental, psychological, but overall, among the 10, 3 steps in Halliwick method involve trunk control and trunk activities. One of the trunk control is trunk control exercise is perform rotation in the axial plane, then another rotation in the frontal, then rotation in the longitudinal plane or axis. This is very common in patients with cerebral palsy and also in stroke. I was opportune at some point during my postgraduate study. We had the opportunity to practice this, and yes, it involves a lot of trunk mobility and trunk exercises. Yes, like I said, we are not very much into hydrotherapy much in this country or in this part of the country where I am. So, but however, I'm just trying to mention this so that we know that not just on a dry land that we can do this exercise. Also, when we have hydrotherapy available to us, we can do these exercises too. Then we have technology-based or technology-assisted exercises too. Not just, yes, this come as a result that there is believed there are some limitations to the conventional or the traditional exercises that we do in our gymnasiums. And also there are some safety concerns in the in our in the activities also that we do using the conventional or the traditional balance exercises. So we know that technology always comes to ease, to make things easier and to make it more efficient and so on. So here I have 3 categories, and one of them is machine assisted. It's called machine assisted because, or maybe I gave it the term machine assisted because it helps the patient in doing the exercise. It's helped the patient in directing the movement physically, just like the touch the physiotherapist would give, is also giving that kind of touch or kind of the direction of the movement. So it's a controlled, goal-directed movement, and there is much safety of there is no much fear of fall. There is reduced stress on joints because what you can do on a certain position, certain movement, this will be done more efficient. So overall, it facilitates movements, and it also bring about much safety. Yes, which is one of our concern. So this is an example of a picture of a machine. I got this from research that was published, and they used this machine. They use this machine to help in back extension and flexion. So you could see that patient will sit here. If it's for flexion, then this particular platform will help in directing the movement of the flexion, or that is the platform will be in front, and the patient will be able to carry out this. And if it's going to be extension, then the position will now change. There are ways they can set the parameters. There is also a screen, which we can see here. They have a screen that you can set the parameters for each of the patient. It can save the activities and many other things. So that's why it's a machine. It helps in many things, recording and conducting the activities and many other things. Yes. Then this is also this similar instrument, but what we have first is for flexion extension. Then the same or similar products is this helps in from the name you can see trunk twister. It helps in trunk rotation from right to left. You can see the lady sitting down there. and they are also, it's also similar. We have this screen here that can set the parameters for the exercise, and the exercise can be conducted with ease. So this is just an example of machine-assisted exercise. Yes. Then you can see biofeedback. Yes. There are a lot of also machines or technologies that have been developed for balance training or exercises for neurological conditions. Yes, they help in multisensory inputs. It could be tactile, it could be visual, it could be auditory. Yes, they help in telling the patient or seeing, the patient will see visually that this is a posture or this is a movement that is supposed to make, and it will try to correct you by giving you auditory feedback, and also maybe probably vibration to tell you that you need to correct the posture, you need to do a certain movement and so on. So there are different ways, there are different forms of this biofeedback machine. And most of the time, you see them, they are targeting also trunk. Like we said, trunk is very important. It's key in the assessment, it's key also in the management of balance impairment for neurological conditions. So we have, it enhances, by giving you the feedback, by giving the patient the feedback, it enhances symmetry, it's improve the posture and the position, and then it's also improve perception. So this is an example of, one of them is a Nintendo game. Yes, we can see here on the top right corner, this is sorry, I got this from a YouTube video, so I took a screenshot. This is the person performing the exercise. It's a game, and he's also standing on a platform. You can see it's a platform. He's standing and is getting instruction from the game to move left and hit the ball, or to move right and hit the ball, or a lot of instruction, and there will be scoring. There will be score as a feedback. There are auditory feedback and visual feedback as well. You can see instruction here: tilt your body left and right to head the footballs flying. The video shows footballs flying, many of them, as many as 5, 6, 7 coming almost at the same time, but at just short interval difference. So if one is stable, is having good balance, coordination, be able to move in all directions, to be able to hit these balls and be able to, so there is a score also for it, like I showed. Yes, so this is just an example of a game. PlayStation also has been used for this, for some of us that use PlayStation. You could see some of these things. Then virtual reality, because the patient will be immersed in a virtual reality, yes, and will be required to perform some tasks, and also there could be scoring and other things. For some of us that have also involved in virtual reality, we're able to understand this very well. Then robot-assisted balance exercises. Robots have also been developed, as they have been developed in various places, in various fields. For balance also, some have been developed. They have been developed to improve safety of home training for patients, to improve efficiency of balance exercise because they are done easily, then efficacy of also the balance exercises. But they have some of their own limitations overall, not just the robot, the technology, because the patient will be highly dependent on the technology, unless that has to be win off, that has to be graduated from the technology to more real life activities. Then high cost of purchase, of course, not just the robots, the machine assisted, the games and all alone are very, very much expensive. Yes. Then, of course, high cost of maintenance. This thing need to be maintained. They need to be powered by electricity, which is sometimes very challenging in our hospitals, and also technical know-how. If these things are acquired, there is need for training to be able to understand how they work. Then there is also need for training of the patients and many other challenges. However, they are still excellent to be used. This is just an example of a robot called BEAR, Balance Exercise Assist Robot, where the patient will stand on the platforms and hold the handles here and will perform some activities, as we can see on the next picture. Picture here, we can see the screen, we can see the patient standing. There's a harness there for safety. We can see various activities that the patient can do. You can see on the screen here, first one. I can see on the second picture, B. We can see on C. I see the patient is skiing. You can see the patient is on a rodeo. Is on a horse here in the on the D is on a horse. It's like rodeo. You can see here is skiing. You can see here is tennis is involved, and many other activities that the robot helps in carrying out as assistance. Okay, this is also another example of robot. You can see the lady sitting down on the machine. You can see the screens there. This is called Robot Trainer 3D BT-3. This is a company name. I don't know what it means, but they have a meaning for it. It's a product. It's a product name. So yes. So all these tasks most of the time are not things that would be used as standalone, just performing one balance exercise or just performing a certain balance exercise. The best way is to combine them. Yes, they make it more complex, though we can start from one. We graduate by combining two, or we graduate by manipulating one or two of the activities that will challenge some other systems, the visual system, the auditory, or whichever one that we have mentioned. And it makes it also multi-system, because many systems are involved in this exercise if we combine them. So let's look at them in a bit. When we have, let's start from the recumbent position up to the standing position. So a lying position, yes, we have activities like rotation. And I've demonstrated last time upper trunk rotation, lower trunk rotation, and we have rolling to the affected side and rolling to the unaffected, just like these lower activities. I mean, these last two activities, rolling to the affected, rolling to the affected. If you remember the trunk control test, this is what was demonstrated. If you remember the trunk impairment scale, these are the first two, upper trunk and lower trunk rotation. Then this thing could be, we have said that we can manipulate some other systems. We can do it in eyes open or eyes closed. We can involve upper limb and lower limb support. These supports will make the exercise more challenging, And we could also bring a very compliant support. For example, lying down, asking the patient to do breathing exercises. So instead of just, yes, patient is able to do breathing exercises, and you want to progress the breathing exercises, you can do it with one limb, with affected, with unaffected. You want to graduate that exercise, you can now bring a very unstable surface, compliant surface. Let's say it's a certain platform that is unstable. Let's say the exercise parts. You place them under the foot and ask the patient to do the breathing exercises. You can bring on the gym ball below the lower limbs, ask the patient to do breathing exercises and many other things. You can do it on a different height. You can do it from a mat, lying down on a mat. You can take the patient up to a Bobart plinth. You can take the patient up to a couch, which is a higher position for the patient to do this task, which will be more challenging for the patient, knowing that is on a higher position, and this he poses a risk of fall and will make it more challenging for the patient. Then different combination of exercise. This is just for bridging, this is just for rolling, and yes, this is just an example of yes, a line into other exercises can be conducted, like the core stability exercises. We can see here, the patient is asked to is doing a call up. This in the first one is having a breathing exercise. This is a call up. We can see here is rotating the lower trunk from one side to the other. Yes. So then we have exercises in sitting position. So a lot of combined exercises could be conducted while in sitting position. From sitting unsupported, we have seen in the function in sitting test, back balance scale, we have seen in trunk impairment scale that first of all, what they just want to see is the patient is able to sit unsupported for 5-10 seconds, showing that it has a good balance. So it could just be sitting unsupported, and also gradually increasing the time from sitting 5 seconds to sitting 10 seconds to sitting 15 seconds to sitting 20 seconds, and so on. In a correct posture, symmetrical, and without support. Then this can be more challenging when you ask the patient to close his or her eyes. So the patient might can find it more difficult and begin to use some compensation, which you need to see and correct. So the patient should just be able to do it unsupported without any compensation. Then upper trunk rotation, which we have demonstrated. I'm going to demonstrate again today. Then lower trunk rotation also. Then lateral flexion of the trunk. We have side sitting. We have pelvic lifting, which we have seen example in trunk impairment scale. It's also just like weight shift also. Side sitting is also serve as sometimes or serves as weight shift also activities of weight shift. So in sitting, you could, yes, also involve reaching out, like we have done in the functional reach test. We have demonstrated some of these things. Then yes, still in sitting position, I've just mentioned that the patient could get involved in reaching out to pick things. Sitting on an unstable surface, just to sit on a pillow or to sit on some inflatable objects. For example, the balance pad I've just mentioned, or the Bosu ball will also be part of it. Then not just sitting, you can sit with two lower limbs resting on an unstable surface too. maybe asking the patient to sit and place the lower limbs on the wobble board, or on the Bosu ball, or on the gym ball, or on the any other unstable platform, or rocker board. They could all be possible. It could be just one limb, it could be two limbs, depending on the level of activity or the function of that individual. Then you could also include perturbations. A patient is sitting, he's just sitting on a stable surface. He's sitting on a stable surface with eyes closed. He's sitting on a stable surface with eyes closed with perturbations. You could be sitting on an unstable surface with eyes closed with perturbation. You can see progression here. Then it can be also done in different heights, from a lower chair to higher chair to couch and many other things. Then kneeling position, 4-point kneeling, 2-point kneeling, half kneeling. You can have trunk activities while in kneeling. There's rotation in 2-point kneeling. You can do rotation in half kneeling. You can do bed dogs exercises and many more. You can do. This is an example of yes, standing position. That could be also, yes, unstable surface here that could be incorporated in the kneeling. Depends on the level of the patient. Also closing of eyes, that's prevention of visual input. Also perturbations could also be part of it. It depends on the level of the function of the severity of the balance. The same thing with standing, just quiet standing, weight shifting, standing with eyes closed or standing with eyes open, perturbations also incorporated, standing on one limb with eyes open, standing on one limb with eyes closed, tandem stance, standing with reaching out, standing on unstable surfaces, standing on unstable surfaces with eyes closed, standing on surfaces with reaching out, and heel raises, toe raises, standing with trunk rotation, perturbation, different heights also. These are also various combinations of activities that could be conducted to improve balance in standing. This is just an example. We are going to look at in a bit. There's walking. We can have just normal walking. We can have the tandem walking. We can have walking sideways. You can have walking sideways with resistance using the TheraBand. You can have walking backwards. You can have normal walking on an unstable surface. You can have the tandem walking on an unstable surface. You can have walking with trying to overcome obstacles, walking on the treadmill, walking on a different height, and eyes open, eyes closed, perturbations, and many other things can be incorporated. Then we have transfers also, which can be also be used to train balance. Lying to sitting, sitting to lying, sitting to standing, standing back to sitting, transfer from bed to chair, and chair back to bed. This can also be done in different platforms, in different different sensory inputs. For example, with eyes open and closed, with doing this on an unstable surface, and so on. Yes. Then we have weight shift, which I just talked a bit about it last time. This is a protocol that we have for weight shift. We have talked about trunk control, and during the practical, I will talk about the PNF and the Bobat forms of exercises, for which in this our discussion today, I will only focus on trunk activities for the PNF and the Bobat. Nothing going outside these two. Yes. To just be for the, yes, for example, using the TheraBand, we can see how this is involving trunk rotation. it's not just the upper limb function or upper limb activity that is involved. We also have the rotation, which is in line with the PNF, and it's also in line with trunk activities that we have mentioned earlier. That it is important while you are treating balance, you focus on the trunk also, because it's one of the, yes, we can also see the same thing using the TheraBand. It depends on where you place it, and for you to be able to allow for rotation while making the movement. The same thing. And she's in 4 points kneeling, and also conducting exercises with rotation using resistance. That's TheraBand. Then we have the wobble board. I've talked about earlier that when prescribing exercise for wobble board, first of all, we need to look at two things. We need to look at the platform of the wobble board. We can see here, we can see here on the picture below, we can see the platform on which the wobble board is placed is circular, and this is going to be most challenging for patient to maintain posture. And we can see the other picture of wobble board on the right top corner. We can see the platform is less circular than the first one. So it means if we want to use wobble board and we feel is what we want to prescribe for the patient to carry out, starting with the one with a less circular base of support would be much more easier to carry out than the one with the circular base of support. Apart from that, the size of the base of support also matters. Some have a wider base of support, like what I can see in this clinic. What we have is wobble board with a larger base of support, which will be easier to carry out task than those with a smaller, like in this picture. We have the wobble board with very small base of support, and it's also circular or half circular, which make it very, very unstable. This will be for probably athletes, although it depends on how we want to use it. But we can see here it's less circular. So if we want to make it very much more stable, it means we need to have a wobble board that has a larger base of support. Larger base of support plus less circular. So when buying wobble board, these are the things that we need to look at. Apart from that, the platform that the patient stand also matters. The size. When you have a wobble board with a larger platform, is also much more, which larger platform is also much stable. When it's smaller, it's difficult to maintain balance on it. Then the surface, not just the area now, we're talking about the nature of the surface of the wobble board. If it is rough or if it is smooth. If it's smooth, of course, it's much more difficult, much more challenging to stand on or to conduct exercises. But if it's rough, there will be some element of friction, and it will be easier to carry out tasks or exercises on it. So that's about wobble board. So what kind of exercises can we do with the wobble board? We can do exercises side to side. just placing the limb, the foot on the wobble board, and okay, we can make a clockwise movement, we can make anti-clockwise movements, then we move side to side, or we shift the weight forward and backward. But this is not necessarily that the patient has to stand with all the two limbs. It could be just the patient is standing, like we can see on the picture here. The one standing is, you can stand with one limb resting on the floor and one limb resting on the wobble board, or it could be that the patient will be sitting. This is a picture I got from from YouTube. Yes, it could be that the patient is very much impaired, having much impairment. It could just start with a sitting position with just one limb. So can make the circular movement, clockwise, anti-clockwise, clockwise, anti-clockwise, then can make the movement forward and backward. You can do it side to side, can do it forward and back. Yes, you can start with one limb just by sitting down. He's able to learn the tasks, then you move to the other limb and do that. Then you can progress to standing position. From standing position, can do it with one limb. Then just like this is not, I actually didn't get the best picture to demonstrate this, but it's just to have idea of what I want to discuss. You can have just one limb standing and one on the wobble board, then conducting the exercises. You can do it with support. That's why I brought this picture. You can do it with support, then later the support can be removed, then later the two limbs can be on the wobble board. Depends on the level of the impairment of the patient. So this is about wobble board. Then rocker boards. They have similar explanation with wobble board. The surface, that's the material, or the surface contact, whether there's going to be friction or not. Then the surface area, the size also matters. Then the base of support, we can see here, will give us almost a smaller base of support, which is almost circular. We can see here another, which is, this gives the more true meaning of the rocker. Yes, we can see has a very wider base of support. So, and we know the rocker, sometimes the movement is just in just forward and backward. That's basically some of the movement, the main movement that could be conducted. So we can choose rocker, which are much more stable than the wobble board. Yes. Okay, this is another example, which is much more stable than the first two I've demonstrated here. Then we have the BOSU board, which is just an abbreviation of these words we can see here, both side up, which make it BOSU, or both sides utilized, either. But the second definition is usually the company name. Okay, sorry, that was echoing, and we tried to resolve the issue. Yes, so it's like half of gym ball, or yes, just half of gym ball. So this is almost similar to the wobble board or the rocker board, because it's also a compliant or unstable surface, and this can also be used to carry out various exercises. I've mentioned it during demonstration, during the discussion of exercise in sitting, standing, and other things. So we can see the first picture here is kneeling, 4-point kneeling on the Bosu board, just trying to maintain the posture, or to be able to conduct exercise on this unstable surface. You can see this is, yeah, of course, these are athletes, they are not patients. Yes. So just standing on one limb, and also doing almost something similar to squatting. Yes, with one limb. You can see the next one standing on one limb on the Bosu board. So this could be also what we have said, like patient sitting down. Patient can sit on this, which is very unstable, and to carry out tasks, to close eyes, to do many things. Then it could also be that the patient will be sitting down, and the foot or feet will be rested on the Bosu board, on the Bosu ball, to be able to carry out tasks, because it will make it more unstable and difficult to carry out tasks. Yes, you can see almost yes, we can see different exercises. This person on the right with the red is marching on the is stepping on the Bosu board, and we have the lady here trying to improve on the core stability muscles using the dog beds exercise, which I've mentioned earlier in one of the list of exercises that can be done in kneeling position. So she's almost in 2-point kneeling position, but one of the hand is off and one of the lower limb is off, and exercises are conducted using that, to using the limbs that are off the floor or the ground. So you can see, just to make the surface more challenging, she placed the limb that is supposed to be resting on a stable floor, and make it more unstable using the Bosu ball. So these are some of the unstable surfaces. Then we have the gym ball. Just sitting down on the gym ball could be used as an unstable surface. Then sitting down to carry out tasks could be also another addition for instability of the platform. Conducting various exercises, like we can see on the picture here, which is abdominal exercises they are trying to conduct, which helps in the trunk control. Like I said, just sitting down. Yes, here's the picture. Lower limb activities with the ball. Yeah, lower limb activities, just sitting down. You can see here, yes, sitting down, but I said that at some point we can add upper limb activities, and these upper limb activities can also be made more difficult by using weights. And we can see the lady here is trying to lift weights while she's sitting on an unstable surface, then conducting upper limb activities with weight. Then we can see more instability, yes, sitting down on the gym ball, then lower limbs placed on a wobble board. We can see two instability. So the instability can be much more increased by asking patient to perform upper limb activities or perform upper limb activities with weights, or all this with eyes closed will make it more unstable, and so on. Then this is a balance pad, and with various lower limb activities. We can see here weight shift to the, we can see weight shift to the left upper limb, sorry, left lower limb. We can see heel raise. We can see toe raise. We can see standing on one limb. So these are various exercises that I've mentioned earlier that can be done in a standing position. So then we have the Bobat, which I've talked about, and the PNF also, which I have mentioned that I'm going to discuss about them. Overall, we I've said, okay, we need strength, we need coordination, we need mobility of those joints, the strength of the muscles that are acting, the coordination of the muscles, and so on. So it's not just the exercises. That is why from the beginning, I gave it balance exercises, not balance training, because when we say balance training, it's more intensive, it's more structured and more encompassing by including many other activities. So I just restrict the term to balance exercises. So it means there could be coordination exercises, there could be strengthening or strength exercises, there could be mobility exercise, and many other things that could be incorporated also. We have mentioned example of using upper limb weights, lower limb weights, and many other things that could be done, or coordination exercises when reaching out and coming back, and many other things. So I think I can maybe take one of some protocols here that are found on the net, published by some studies. The citation is at the notes of this, which will not be displayed. Yes. This is just an example of, okay, let's look at weight shift. So this is a certain protocol, standing with your feet. That's how to carry out this weight shift. Standing with your feet hip apart. So that's just at a small, just not more than the width of the position of where the hips are. Then spread your weight equally over both legs. That is weight shift. Just making sure patients stand on both lower limbs. For example, the neurological patient that we can see, especially stroke patients, we'll see them that they try to place weight on the unaffected side. And that's why also during the gait pattern, while they are walking, I demonstrated that last time during the assessment, that what they do is they have shortened stance phase, and especially the mid stance. The moment they stand on the affected one, they quickly go back to this. So this is one of the things that helps in also maintaining the even distribution of weight, which also helps in the gait and also in the stance phase, especially the mid stance. So shift your weight to your right side. Then lift your left off the floor. Patient, this can be done in various ways. It could just be that the patient will just be moving to one side, just the physio facilitating, the patient should shift weight to the side that he wants to go. For example, here we have the right side, asking the patient to just shift weight to the right side, then not necessarily lifting the foot, but this can also be done. Shifting weight to the right side, then lifting the left foot off the floor to ensure that the patient is standing on the right foot that is required. Hold the position as long as you can keep good form, probably up to 30 seconds, then returning to the starting position and doing that over. Then doing that with unaffected side. This is an example of weight shift. Then standing on one limb, single leg stance, for example, single leg balance exercise. Just the instruction is to stand with 1 foot, then is also to stand, then to lift the where you want to place the weight on which limb do you want to place it. Then you ask the patient to lift the other one. For example, here we have lift your lift your left leg off, or lift your left lower limb off the floor and bend it backward at the knee. So this is too hard at first. Stand on one leg while you hold on something, like just what I showed for the unstable surface. So also for the stable surface, you can just ask the patient to stand. If you cannot do that, you can hold the chair or the couch or the table that is standing close to. Then just something that you can hold that is heavy enough to hold him not to fall down together with the object, because it's not too heavy enough to hold him or her in that position. Also to keep in that position for about 30 seconds, then return to the starting position, and also try it on the other limb, on the other lower limb. So let's say now lifting the right lower limb and doing that and repeating. So by this, you can increase the duration from 30 seconds is able to do 30 seconds, increase it to 35 seconds, increase it to 40 seconds, increase it to 50 seconds, and so on. Or you can increase the number of repetition. It's doing it 30 seconds once, is able to do it. Then next you have to increase it to 30 seconds twice, 30 seconds 3 times, and so on, up to the time that you can do it, let's say for 1 minute, 1.5 minutes straight. So if it's able to do that, like the picture I've demonstrated, we can try on stable surface, maybe the wobble board or the Bosu ball or the rocker board or many other things that are unstable that will allow for the patient to stand. Yes. Then trunk control exercises, which we are going to demonstrate during the practical sessions. Then these are also other protocols that I've shown. I've shown this during the presentation. We have exercises for the lying position. You have supine position. This is a protocol that was used for a certain research, an RCT. So what they did was for each of the exercise, overall the whole duration is 120 seconds. That's 2 minutes. So they do 2 sets for each, 2 sets for each 20 seconds. So overall we have 120 seconds. That is this bridging for 20 seconds, 2 sets, calls off for 20 seconds, 2 sets, rotation for 20 seconds, 2 sets. Then it's also the same study. They have tasks in a sitting position. This is a complete protocol from activities in lying, activities in sitting, and activities in standing. So this is for the sitting position. They have the tasks for sitting, not just sitting, they incorporated reaching activities. they have the target to reach out at 45 degrees from the patient, and which was measured 120% length of the patient, length of the arm of the upper limb of the patient. So if the patient is able to, the patient will reach out to the right side, then there'll be another there'll be another object to reach out on the other side, which you can see here. Then patient will reach out at 120% at the beginning. If he's able to do that, then the target will be graduated, will be moved from 120 degrees to 10% will be progressed. Then, and so on, 10%, 10%, up to the limits where the patient can be able to reach out. If the patient is unable to do it, then they'll take it back to the previous position where he was. For example, he was placed at 120% of the length of the upper limb, then the progression is 10%, that will be 140%. If he's unable to do it, you take it back to that 120%, but they added 1% to it to make it 121%. That is not just exactly the position that was left before. Until when he's able to do it, you add 10% and so on. Then we have for standing, yes. What they had for the standing in the protocol is to have also 120% length of the upper limb. Then you have an object. Then you have or a small hoop, an object or small hoop that you have to place over a certain distance. Then the patient will reach out at 120. If he's able to do it, 10% of the length will also be increased, will be graduated gradually, progressing. If he's able to, if he's unable to do it just like that of the sitting, we'll just add, we'll just take it back to where it is and just add 1%. We'll do it on the right side and reaching to the left side. The patient will do it with the unaffected upper limb. Will reach to the right side and which will reach to the left side. Yes, this is done, as we can see. There is a platform there, which is is being graduated to do it on unstable platform, to be able to do it. So if the patient is able to reach the limits, then we now introduce unstable platform and so on, making it difficult more and more. So this is just an example of protocols that we can see. These are from some studies. I think there's another protocol also. Let me just check where it is. Yes, this is another protocol. We have the incorporated weight shifting, the toe raise, weight shifting with half tandem and heel raise, then heel toe standing, then one leg standing. So we can see here what they have is weight shifting exercise with feet parallel together. Just like in the other protocol that we have mentioned, patient is just standing with with just the foot by the side, with the feet by the side, right by the side of the left. Then weight shift heel to toe. The patient is asked to have it to modify the movement. You shift weight side to side, right to left, right lower limb to left lower limb, or you shift weight forward and to backward. That is to heel and to the toe. So this time around is not side to side like in the other protocol. This time around is move forward, and it's not like move forward, it's to sway forward and to sway back. Then toe raise, standing with feet hip width apart. Slowly lift the foot, the front feet, sorry, standing with the feet apart, slowly lower the front feet. So just like the picture I have demonstrated, the patient will lift off will raise the toe from the name of the exercise. Toe raise will raise the toes. That means you'll be standing on the heel. Then weight shift exercise with feet in half tandem. So it's not full tandem, just standing just halfway through tandem. Then the patient will be swaying, will be shifting weight from one side to the other, instead of just keeping the feet by the side. Then heel raise. This time around, the heel will be raised, and the patient will be standing on the toes. So he will raise, or she will raise the heel gradually up and slowly back. Then heel toe standing. Then one leg standing, hold stability exercises, and so on. So I think the theoretical aspects we'll have to pause at this time. If there are some questions or observations or corrections, we can discuss on it, so that we'll come back for the second session, which is going to be some practical demonstration. Thank you very much. Yeah, I think somebody's raising hand. Yes, we can. Yeah, you can go ahead with the observation or questions.
Yeah, I am Egitai Olufemi Ayodeji. Is
Okay,
a sort
sir.
of contribution. Is a sort of contribution. I think
Okay,
when
sir.
it comes to when it comes to the level of this, I think it depends on the level of the level of experience and expertness of the physiotherapist taking in charge
Yes,
of the
sir.
patient.
Yes, sir. Yes, sir. Yes, I agree 100%. Thank you.
Okay, sir.
Yes, sir.
Okay.
Thank you very much. I think thank you for calling my attention. I think many things I've been talking about the patients alone, and yes, it's quite important that we also talk about the expertise and the experience of also the physios. So I think most of these things could be done under guidance for, let's say, entry point physios and junior colleagues. They could learn from experience from our senior colleagues, yes, before handling patients alone, because like I said, there are a lot of risks, even from assessment, and a lot of risks with assessment, not to mention the treatment.
Yes.
And that's why I said also it depends on the level of severity of the patient. And most of the time, we just try to involve only mild to moderate severity of neurological conditions, and starting also from sitting, from lying and sitting position. Yes.
Okay, sir. Okay.
Yes, thank you very much. I really appreciate this. I think that was a statement I just watched some weeks back about experience, and I think many people tend to underestimate experience. And one of the things is that somebody was trying to explain this experience. That imagine that somebody wants to drive a car, for example, a manual car, and he was taught how to trafficate, how to navigate the road, how to turn the steering wheel, how to put on the gear, how to make it free, how to do everything. All these will be taught, for example, in a class or even in the car. But the next thing you ask the patient to navigate, to drive the car, maybe a chaotic situation. So that is one of the things with experience. And thank God you are here. You have brought my attention, and thank you for that. These things, yes, they require experience, of course. Thank you very much. So, any other question or contribution as well, because we are all in the learning ground. Yes, the knowledge is very wide. There could be some things I've missed out. Yes, it's possible. There are some things that need to be added. We can discuss. Then maybe after the break, we can go for the some practical demonstration to see this thing. Okay.
So my question is about balance. There's a patient that it's obvious that he has weakness on the lower limb, so he cannot stand balanced.
Because the patient is having weakness in the lower limb.
Yes.
But then, sir, when I start treating it, seems like we are gaining the strength in the lower limb, but still he cannot maintain his balance.
Yes.
So is it that we use the trunk, or we can only focus on that lower limb?
Yes. I've said this in the previous presentation, that balance is not just one aspect or one system. The musculoskeletal system is there, the sensory systems are there, the perception, many other things are there. Then the body parts, also you look at the upper limb, the lower limb, the trunk, and many other parts also that are involved. Maybe you only focus on the lower limb assessment, but what is the level of impairment in the trunk, which will also tell you whether it's trunk or not. Although we have mentioned that trunk is key, is one of the most important things, because it's the platform for all the limb movement, is the core area for many activities that we conduct. And that's why I think we have taken enough time last time to see how we can assess trunk. Then before the management, I think you go back, you just check if the trunk is okay, all the various movements, the strength, the coordination of the movement in the trunk. Yes, then you can now draw conclusion whether it's the trunk or not. What is missing in the trunk, then you train that. If it's not the trunk, then it could be from the lower limb first, or it could be from some other part of the body or some other system. That's why holistic assessment is key. Yes, sir. I saw another hand raising.
Yeah, it's me again.
Yes,
Yeah,
yes, sir.
so
Thank you. Thank you. Yeah, thank you for coming back. Yes.
I think the best thing for us when it comes to the usual of is balancing.
Yes, sir.
As regards to, I think the first thing we're supposed to put into consideration is the psychological effect and aspect on the patient prior to when
Yes.
even the treatment will commence.
Yes,
Because
sir.
I want to put in something. There was a patient I was seeing some times ago. She's of moderate height and weight.
Yes.
Due to the fact that she do have this aspect of falling when she happens to be at home. When she comes to the clinic, anytime we compel her to be able to walk,
To go for upright position, she'll be resisting.
The fear is always there. Don't worry, not only me, even my colleagues there, we are there.
Yeah.
Two of us holding him so that he can be.
Yes.
The fear is still
Yes.
there. But I think it's better
Yes.
to let them realize that, okay, now,
Yes.
which one?
Yes.
There's no way you can fall when we are within here. We are within the parallel bar. We are with you.
Yes.
So the woman refused.
Yes.
And at the end of the day, she refused to come again because of fall. She says she would rather be at
Yes.
home than fall
Yes.
again.
Yes. 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 That's true. That's true. I mentioned this also at the beginning of the presentation, because I've mentioned that we graduate. Of course, I say we graduate from sitting and standing, and I've said we need to demonstrate. The patient need to understand the safety concern. And while we are making the assessment, also in the previous weeks, I've mentioned that the patient is here to prevent. All your aim is to prevent fall. All the target is to prevent fall. That is why that's why we are assessing, and that's why we are going to treat the balance if we find out that there is an impairment. So I also mentioned that during the assessment, in the previous weeks that we had the workshop, that it shouldn't be that we are assessing balance and we now cause what we are trying to prevent. That would be catastrophic, because that patient would never want to go back to anything similar to it, be it assessment, be it management, be it any function that will involve that. So that's why I mentioned something about this. The psychological, of course, I've said as one of the factors that may affect the assessment and also treatment is the cognitive function. That they need to understand what you want to do. They need to understand the instruction. They need to be able to follow it bit by bit. And we need to make sure that if they have previous history of fall, we need to reassure them. We need to make sure that the environment is safe. They are standing in the parallel bar. If we have harness, they can use it. If they can stand on a chair, which is farm chair, or if they can stand close to a couch that they can easily hold, and the physios that maybe 1, 2, or as the number may require, to stay close by to them to help in make sure that the procedure is safe, be it assessment or the treatment. And yes, the previous history of fall, the psychological aspect you have mentioned, they are all key. I think I've mentioned a few times in the previous workshop that because the previous workshop we had about it's about assessments. We had the theoretical aspect and we had the practical aspect of the assessment. That all the time, at every point in time, I always try to bring up issue of safety, and that's why also today in this presentation I brought also a slide about safety, and I brought about a slide about factors that will affect the procedure. Let's say age, that I talk about the premorbid condition, the severity of the condition, and many things. I also added about trunk function. So thank you very much once again. Thank you very much. Yes, there's a comment also in the comment section, and thank you for the comment. Yes, I think it's a line. Yes, those with previous history have difficulty trying to execute this tasks of assessment of balance, and also balance training or balance exercises for especially neurological patient. I've also mentioned this at the beginning. I think during the introductory aspects, let me go back to the slide. I said, yes, balance exercises are applicable to all, be it orthopedic, neurological conditions, athletes, and many of them. That's why some of the things that we could find on the text or literature, they could be for athletes, yes. But when we have the neurological patient usually requires supervision. And that's why I've mentioned this clear on this slide. And I've also mentioned that, okay, all these factors I've talked about that we need to consider. And I've said that, yes, you can do it at home, but most of the time when we have this technological advancement, that's when we can do it at home. And when they have also reached at certain advanced level, that's when this thing can be done at home, but with supervision of the home visit physio or somebody that has been trained to be able to carry out those tasks. Thank you very much. So any more contribution? Thank you. I really appreciate this contribution. Yeah, it's a learning ground for all of us. Thank you.
Thank you, everyone. We can go for the break for one hour. So that to convene at 1:15. Thank you. Well, Now the on this one.
Okay, welcome back to yet another session, continuation of the previous session that we started in the morning. Like I said, I'm going to be demonstrating some of these things that we have discussed in theory. And in addition, I said I'll talk about the parts and the elements that should be towards the end of the other basic work that we're going to see. So, from the slides, we have always advocated for safety for the level of the payment balance that the patient can be able to do. So we start from the minimum that the patient will do. So as I'm projecting on the slide, we start from lying position. We start from lying position, going into sitting position, going into kneeling position, going into standing, combination of various activities. So these things depends on the level of impairment of the patients, depends on the function of this various systems that we talk about. For example, use trunk impairment scale. Patient cannot sit spot 0. Patient cannot sit for 90 seconds. Spot 0. That means you can't do many activities. Or at least you have to patient to so probably you have to start lying position, going into sitting position, where by then you're able to achieve that position, then work on it and progress. So also combining various types. So set in lying position, upper trunk position, lower position, rolling. I think for those that were previous workshop, two things I've illustrated it for now. I'll do that. Like what I showed other protocol that they use rolling. They use rolling. They use O2. They also use cost of exercise. They use timing 20 seconds. So it depends on the patient's level of care. 5 seconds, 10 seconds, 20 seconds, progressing. And the only thing that you can do for 5 seconds, 2 sets, for 5 seconds, for 3 sets, for 5 seconds, 4 sets, for 10 seconds, 2 sets, and so on. It depends. You can be progressing. Difficult. So we can start with the rolling. This is rolling. Let's say rolling to the affected side and rolling to the unaffected side. Count. You can find the exercise by number of repetitions. 1, 2, 3, 4, 5, 9, 8. Count how many is able to do within 5 seconds. This is only like a projected slide. Then you have to apart from sorry, lower from. There's a bit of exercise that very good exercise for also, but apart from so you also mention other exercises. Talk about what are projects, the columns, or just the next. Yes, the column that mention. We can do the region, the global region, up, down. Surfaces. New region. Big size of challenge. Not difficult for you. So you can see I'm on the ball. The 2 legs, 2 weeks. Yes. But when it's on one, then it's more challenging. So it depends on the size of the size also determine how makes it difficult or easier. See the ball is swaying from one side to another. I'm not just breathing, and I'm also trying to keep ball position so that not for that. This is just for breathing. This is for lying position. Talk about the breathing exercise. So this could be done. You can take it higher and do it on a couch. This is not the best couch to do it because on solar surface area. So if you want planes we have the less will be the best because you can roll and roll because of the size. It's almost as size as mat. That's the sense of it, not just lying down in a small place and doing the exercise. One of the things is for rolling other exercises for the body. So this might not be the best. You have a larger plate, about plate, that would be best. So you can do the breathing here, you can do the columns. Yes, you can do it with one hand affected, unaffected. Then we can also have the unstable surface, the ball, for example. You can have the ball. Like I said, this is not a good because of the purpose. I'm repeating our safety all the time. Yes. It's becoming more challenging. One, see, when I was floor, I could do it with one leg, but here, because of the height, it's becoming more difficult because it's more higher. So we can also this region have a stable surface. So, as patient is just lying down and active phase, you can also detect problem with the balance. If patient asymmetrically lying down, the head, the trunk, not lying upon the shoulders, you know that there's probably weakness in the trunk. That's if it's at active stage, will not do many things. At least just keeping the patient in a position, symmetrical position, lying down, the board is up to the level that the patient can tolerate stages. And I'll go to sitting.
Chat audio, chat audio.
It's already evolved.
Yes, the audio.
And I can see the video. Yes. As well. People start writing their notes.
Yes, they are ready.
Time.
Yes.
Hello, can you hear me? Now from live. How much is 5 seconds? Right. Also, we don't have a check. down. Also, yes. What more time? Voila. Motivations. Right. Or try to bring on contribution. So, see that the patient is and the platform for the lower limb is stable. Or it could be that the platform for the lower limb is stable. One is sitting down and just sitting down to maintain the comfort. Now, I'm asking the patient to breathe. Can you touch my hand? We have to do something. For two legs, for two legs, one leg, another leg. Another example of several projects, local one or balance part. Because this has a wider space here. I don't want to be sure, but I also see the platform. Wider. Much more stable. Yes. And then the concept as well as the while maintaining so the patient can sit down and perform lower limb start forward, backward, forward, forward, backward. Then you can do it as clockwise. Now I move on for going so it will be that exercise you want to do. I don't use one thing. One system. Side to side. And clockwise. One thing. Forward, backward. Even if the target is balance training or perspective training. So I'm sitting on an unstable surface and also back on forward. Right? What can I do? I can't see anything. So now look for athletes. Go advanced. Once you have your cover, but you can use that. You have to focus the format. What does it also you can try the yeah, it's an unstable. Yes, that would be used. You can use stable depends on the patient. Some of the exercises one is dual task. Different heights. Different heights. One, chair, house, house, really. House, really. The patient five tenths of how many sets down and half exercise. How much of this five tenths of five. Also at this point, you can also use the platform. One. Then you have different time. The dogs. Culture. Just like the number how why do that? Wow. And it's but all this is you are around the patient, you are doing this private part, you are in a safe environment, you are around the patient, you are holding the patient, you guidance. Also, different understanding and yes. And what's next? Understanding, which understanding. It's not like you are flexing. Wait, you only have the body you are moving. Don't yeah, we or you are whole body very so one this people who work is not all the time they will have to stand on start with one week. Patient cannot do cannot do this what ask me this is not very much safe. When college are you cannot then try the exercise forward, backward, side to side, clockwise. Clockwise, you are winning and clockwise. Clockwise, then clockwise.
The volume is low.
Okay. Starting with the part, yes. Just wait for the and your hands. And lift your left leg off. Off. So this is because you can get the support. Something that's strong. Something like then after that,
this, then they can also have a stable surface, like you also go pillow or any other thing that is stable. Then let's look at protocol, yes. We think which shifts they have, we remove side to side. The other side. Then forward. Forward. Now you raise your toes. Raise your toes up. Yes. Raise it up. Maybe this support. Now, how is it I'm able to do it without support? I cannot do it. Yeah? Okay. You raise your toes. Then the other way, you can now raise your feet. For 10, 15, or 30 seconds. Then we do another weight shift, but which is more complex, is half tandem. Not completely tandem, but we go half tandem, yes. And now we shift weight to this side. We can shift weight to this side and shift weight to the other. Then upon the knee raise, one leg starts, one leg starts, and into standing. Just standing, and then this one. So based on the available guidance we have, these are some exercise we can use. So the item here, so balance. Then, like I said, we can look into other concepts. Not about which we are going to look at. So just sit down. We have a patient who is, let's say we have a patient who is unable to lift the pelvis, is unable to fact, and this unable to stretch, lengthen side. Using the Boba's concept, straighten this from which onto the do this. You have which one to side to this side. You also have lengthening side. Remember to have okay. So facilitate education is unable to flex your trunk or lift the pelvis or shift weight to the side, then you can use this to facilitate. This is one way. You are facilitating weight shift. You are also facilitating lengthening. The opposite side, you are also facilitating contraction, shortening of this other side. There should be effort from the patient. Same thing with focus this side. You cannot do it. You facilitate. That's the position. So this for the pelvis, for the lower trunk. Then demonstrated also last time for when patient is unable to rotate the lower trunk. And obviously, we're going to do the anterior and inferior. For example, we're asking to go in or out. And it has difficulty going back. We can also facilitate. Now, move forward. And do this on the mat. Okay. Like I said, that's why you have Robert plates. That's why you have this white. These are some of the exercises that you do with Robert. So, and also come forward. Then you can also facilitate. So this for rotation. Rotation of the lower. What it is? Upper. I know we have to that question. Upper. Simple as help the patient to move forward, move the left side forward, then left side, right side, left side, right side, left side, right side. What you can do is you just kind of how to do it. Please. The right side, left side, right side. If it's stronger, you can give resistance as is going, but you have a problem that the patient cannot even do it. Want to facilitate. But I'm showing ways that you can facilitate the problem. So, do this. Do this. You can also incorporate with the rotation. You can also reaching out to make sure that the patient rotates. Reach out. Back. Directing the rotation. All this you can do it with additional instability with the platform. With the lower, you can add ball, you can add the zoom ball, you can add the smaller balls for the patient to stand. I think this this is not just reaching out. From how to place hands on my body So these are a few things about what concept. I think I tried to do this last time. I know I'm keeping this last aspect. We are also going to involve trunk rotation for the PNF. Can you lie down on the right side, yes, on the right side. What we want to do is we want to combine trunk rotation, pelvic rotation, scapular, pelvic and scapular. And we know, I don't know if for those that have joined the workshop last year, that we had a PNF, for those that have some background for the patterns, we know that we have diagonal 1 and we have diagonal 2. So this is diagonal 1, and this is diagonal 1 into anterior elevation. This is diagonal 1 into posterior depression of the scapula. This is anterior elevation. This is posterior depression. This is not the best position I'm standing. I will stand here or behind. Let's change. Is okay this side? No, even this side is okay. I'll have to just standing position. Just stand behind you. Or because you know the position of the thread is also diagonal. So given the diagonal movement, this is anterior elevation and posterior depression. Anterior elevation and posterior depression. Right? This is a posterior elevation and anterior depression. Posterior elevation and anterior depression. Sorry, posterior elevation, yes, anterior depression. The same thing for the pelvis. We have anterior elevation, posterior depression, anterior elevation, posterior depression, anterior elevation, and posterior depression, anterior elevation, and posterior depression. Then we have also the same thing, just like this scapula. We have the posterior elevation and anterior depression. Posterior elevation and anterior depression. Yes. So there are various techniques that I've mentioned. For those that have joined last year, we can have rhythmic initiation. We can also have combination of techniques for trunk exercises. We want to combine the pelvic and scapular patterns. One of the best methods or techniques we can use is the combination of isotones. The video is freezing. Like that for past. Okay, it's network, but here there's no problem. Yes, well, here it is. So I'm trying to look this as feedback. Okay, so now we can combine anterior elevation and posterior depression for the scapula and pelvis. This is anterior elevation, posterior depression, and anterior elevation of scapula and pelvis. So we can apply a technique now in combination of isotonics. Combination of isotonics here is you are combining two isotonic movements. You are combining the eccentric and the concentric muscle, which you are going to combine. I know we will find it very difficult to understand this. Yes, because the is very confusing and very technical concept. Yes. So we have the eccentric, for example, for the scapular pattern. If you go into anterior elevation, for example, up, you take to the anterior elevation, up. So this is the eccentric. Sorry, this is the concentric. Back is the eccentric. Up is eccentric. Back is concentric. Up, eccentric. Back is concentric. So now we are going to find them. You go into anterior elevation. So you like sit on my hand. Yes. Then you go back. You are going to go back gradually. When you hold this, you are pushing against my resistance, right? You are pushing against my resistance. Then you hold. Now I'm going to move you back. Now I'm going against you. Hold. Let's go back. Reverse it. Yes. Hold and go back. Hold and push. Yes, push against my resistance. Hold. Now I'm going against your resistance. Gradually. This combination. Upper limb, scapular pattern 1 into anterior elevation. posterior depression, then third pattern D1, anterior depression, using combination of isotones. There are other, this is for coordination, for example, coordination of vision. You want to improve coordination. Coordination of system is usually coordination because you have the same multiple centric and the same multiple centric. But other techniques that go to the dynamic stabilization, dynamic reversal, they are for strength. I think very by this time we should come to the end of session. If there's any question, contribution, take that. Any question? Sure. That is last part. Yeah. I know questions will come from there. It seems because I don't think the patient will take understand the pattern and the way the resistance. Yes, I have skipped like 10 steps and straight maybe they'll tell you I've skipped. He was part of the workshop, that's why he's able to follow it well. Yes, when I saw him coming, I was very happy that I was able to do this. Because I know if I now use you as subject to do this, it will be a chaos. So it's a bit patient. I've said it last time that when we were having the workshop, you could see if your therapist is also trying, as the terms I'm using are anterior elevation, posterior depression, all those movements go up, down. Even if your therapist sometimes is difficult to comprehend, then you have to also use the terms, simpler terms for patient. Go up, move your scapula towards your eyes, bring it down. Hold. Let me move you. Now, move me back, small, little, gradually, slowly. Let me move you up, and so on. Like I said, I have skipped, I don't know, up to 10, 20 steps before. So it's supposed to, there's supposed to be some background. That's why I didn't put anything inside. There's supposed to be some background before, and that's why I left the general. Because is it effective as is it effective what? Like if the patient one of the principles that's even if it's psychological input that is watching is well along with you. You understand? Even if it's that is as long as we that's why one internal pattern, for example, patient, you ask the patient watch. It's not looking at if it's not looking at it, it's not following. It's not following. Start from one. Let's say the one into flexion. One flexion. Start come to the position. As fingers right from this position. Or you need to be watching him, whether he's looking at it or not. And as you can most of the patient, whether motor inputs, just whether visual, mental. That's why we say there are a lot of other principles. Like I said, it's just like you're jumping from. Yes, I will do it just fast. You have to bring one or two things for them to make sure that they are participating in it. Okay. I've seen that documentation many times. I want to see that because really, I don't want to even talk because PLM is not slash. PM is not slash PLM. Well, right, so they are not. They are not. You can't say PM slash PLM because PLM is a lot more. You see, we have principles, we have procedures, you have posture, you have patterns of movement, you have technique you apply. What I believe most of us what we are doing is not just lift my hand into diagonal and come back. And I've also demonstrated in one workshop that it's not just the movement and coming back. The movement is three-dimensional. It's three-dimensional. The shoulder alone is going into flexion, it's going into adduction, and going into external rotation, and the reverse while coming back. That's already shown like there is movement in the elbow, there is movement in the stimulation and position, stimulates the fingers. Understand? Then you have to choose a certain technique. I just mentioned one combination of myself. We have the dynamic initiation, we have relaxation technique, contact relax, full relax, we have dynamic reversal, we have dynamic stabilization. There are some of the dynamics. So I believe we just do PM. That's all.
Yes, it's very
PM with the pattern.
the pattern of PNL.
I don't think the pattern is what we actually need. So please, is there any question? Response from
No
that's
question.
my 5 minutes. I'm glad there is a real workshop here. At least I'm able to say some things that I cannot take. If alone, people at any level that we teach, we don't have time to teach. Because imagine you to just teach that to take you like people to do that. Which by then you are in the next topic, they'll tell you the semester is you have to write exam. Then you have to write exam. So that's why everything you just take little and just take little and just take it. The only true workshop you know seminars like this. I remember that was expected I tried to put together. I think it started with 30 number and there are only 4 or 5 people. I was going there early in the morning around then before students. I can't remember what class. So we started to I think they find it difficult. They don't understand it. I don't know why. That is stress. Only some years back now, started to do some. Is there any question?
No. So any question, comment, or contribution? So in the absence of any question, you can call it a day. Thank you, everyone.
Mm-hmm.